Thank you very much. You hear me well? Okay, I will shout. I am going to talk about geographical spreading of infectious diseases. I did not prepare a slide to motivate why I am talking on spreading of infectious diseases in a NetSci conference. I hope that it is clear to everybody that infectious diseases are spread in populations via certain types of interactions, ranging from face-to-face interactions for spreading of influenza-like illnesses to much closer contacts, for instance, in the case of HIV. I am going to mainly talk about two projects. First one is a software we have developed for understanding and projecting the unfolding of pandemics. The model is called GLIM, Global Epidemic and Mobility Model. It is based on a reaction diffusion framework in which the world population is divided into census areas that are coupled through movements of individuals among those subpopulations. We have a good resolution data on the distribution of population over the globe, which are given at a resolution of more or less 25 by 25 kilometers squared, for each of which we know the estimated number of individuals living in each one of these cells that are assigned to the closest main transportation hubs in the system, which are determined by the locations of the world airports. In the second layer of the model, we have two types of mobility networks. The first one is given by short-range movements of individuals corresponding to commuting fluxes, for which we have for more than 30 countries the real data that we use to produce synthetic networks for the countries where we do not have data. So we have a complete set of commuting networks all over the world. The second mobility network is given by air travels of individuals, for which we have the number of seats available on each direct connections among more than 3,400 airports. In the third layer, we have a simple description of how the disease dynamics would work. This is an example for the baseline scenario that we use for influenza-like illnesses, in which we attribute individuals we classify individuals with only a couple of attributes depending on their status with respect to the disease. What I am going to mostly focus is the type of interventions which could be applied during a real pandemic situation, and also will give some theoretical insights for the cases where interventions do not really work. Okay, I will extensively use the example of the last pandemic in 2009. The picture is quite ugly. It didn't came out very well, but towards the end of April, in 2009, it was internationally declared that there was an outbreak in Mexico. By the time of the international warning, before that time, actually, it was already spread to couple of other countries, US and Canada. Right after the announcement, we got to know that in a couple of days, several countries in Europe were infected. Right after, in a very short time, in a scale of a month, it was spread to all of the continents. So at that time, we had questions ourselves that we had the GLIM already at work. The aim was to understand whether we could do real-time predictions on the unfolding of the pandemic. What were the ingredients which had to be put into the model? Another thing is studying what-if scenarios that I am going to show you. The traditional approach in computational epidemiology to determine the unknown parameters is based on mostly number of reported cases in given locations. However, we got to know very well at that time that the reported cases were not reliable. They were just underestimations of what was going on in a location. So we decided to take another path using the advantage of the mobility data set we had. Since the model is based on a metapopulation approach and the epidemic is driven by movements of individuals, we had decided to use the arrival time of first infected individuals to a set of countries which were directly seeded by Mexico. We have generated millions of simulations in order to estimate some of the key parameters, one of which is basic reproductive number. That determines, the definition is the average number of infectious individuals which would be generated by a typical infectious person during her infectious period. That is the key parameter in determining whether an infectious disease is going to take off in the population or will die out. And it also determines the extent of interventions that you have to put at work. From the Monte Carlo maximum likelihood analysis, we have maximized the probability of observing the given arrival time of infection to 12 countries seeded by Mexico spontaneously, which gave us a best estimate for the basic reproductive number in tropics, which was slightly less than 2. It means that on average, an infectious person would generate 2 other infectious individuals. Another parameter was the impact of seasonality, which is modeled by a sinusoidal function. You know that influenza is seasonal. So in winter, you have the highest transmission among individuals, while in summer, it is the lowest. Alpha mean gives the variation in the amplitude between summer and winter periods. It turned out to be 0.65, and for common cold, it is thought to be around 0.1. So it was quite mild. The reduction you would get in R0 during winter does not take the reproductive number below 1. So even in summer months, it would not stop spreading. And in fact, in summer, it was spreading, and pandemic had summer and winter waves in the northern hemisphere. I am just going. After the estimation, we made a lot of projections, of course, in order to determine where it is going to be spread and what would be the peak of the, when we would observe the peak of the daily number of infected cases. by the time we made these predictions, it was summer 2009. We did not have any means of validating the results, actually. For the validation, we got data a year after everything was over. I will just show those results, where here, with the blue bars, you see the timing of the peak of the epidemic activity, which is given by the newly infected, by the number of newly infected individuals at a given time. The other bars, the colored bars from yellow to red, gives the peak of the activities in certain countries using some proxy measures like the frequency of hospital visits for ILA, like illnesses, or in some cases it was the number of confirmed cases in certain locations. You see that the model within the reference ranges is able to predict the more or less what was going to happen in those countries, where I am just showing a subset of them. Usually the peak for common flu is observed in February, around February and March. So the peak we had predicted in the northern hemisphere was much, much earlier compared to the common flu. It was ranging from mid-October to mid-December, let's say. That was very important for intervention policies and to understand how much, to understand the timing of the maximum burden you would have in your health system. Then, at the time, we didn't know that the predictions were reliable or not, but we said, let's assume that they are correct and let's try some intervention strategies. One of them was the implementation of vaccination campaigns that were scheduled to be started in mid-October. However, then in reality, it didn't really work like this. Some countries started much later because vaccines were not ready, and also the population coverage was widely varying among countries. Here I am just showing the profiles for a couple of countries, where the gray curve gives you the baseline case scenario in which you do not have any vaccination. You see that in the US, peak is around mid-October if you had not started vaccination earlier. And here the vaccinations in the simulation start on October 15. You see that if the campaigns start very close to the peak, you do not really have significant impact neither on timing nor on the amplitude, which is given by the black curves. If you could start the vaccination a bit earlier than the peak of the epidemic without interventions, then you have a larger impact, but a larger impact in the amplitude, but it doesn't tell you actually whether the cumulative number of cases would be reduced or not. And in fact, in none of the cases we observed a significant reduction in the cumulative number of infected individuals. Okay, this doesn't, of course, tell you that we should not vaccinate. Vaccination is very important, but it has to be done timely. So if you are able to immune a fraction of your population early in pandemic, then you could even stop the spreading. With the other colored curves, you see the impact of, for instance, if we had treatment of individuals with antivirals, the best scenario would be that you start the vaccination at that given time in the middle of mid-October because the vaccines were not available before. But you treat 30% of infected individuals with antivirals, starting at the very beginning of the pandemic. Then you would have, which is given by the red curves, then you would have a very significant reduction both in the cumulative number of cases, also in the peak of the activity. So the burden in the health system or in the population would be much more reduced and more spread in time. Of course, saying that antivirals are not used may not be good to be used commonly because some strains develops resistance when you start using very high levels of antivirals. However, for H1N1 strain, the virus did not really show any resistance to antivirals that are available now. So it could be a strategy to reduce both the cumulative number of cases, also to reduce the burden you would have in the health system. Another intervention strategy, which is always questions during pandemics, is since the spreading is driven by mobility of individuals, why don't we just reduce our travels? Some countries, right after the international announcement of the outbreak, have applied some bans to direct flights to from Mexico. Some of them kept the bans for a very limited duration, but some countries like China could not recover, for instance, the connections after they put the bans by the end of the year almost. And from the statistics of travels to from Mexico, we have seen that there was a reduction in the volume. And the largest reduction was observed during May 2009 of about 40%. Then we asked, okay, let's do the reduction at a larger volume, starting from 50% to 90% on all direct flights to from Mexico. And let's observe the number of, the delay in the arrival time of first infected individuals in each of the countries. Here I am just showing a subset of them. Even if you reduce traffic by 90%, you would not get a delay in the arrival time of infection more than 3 weeks. And 3 weeks wasn't going to be enough for the vaccines to be ready. So it is not, in this sense, would have any impact. However, it could make some countries gain time in order to prepare their system to cope with the pandemic, for instance, the health system. We already knew that travel restrictions were not really effective. So, and there have been a couple of theoretical works. I am going to show one of them here in order to explain why they are not indeed effective. Using an example where I am using an SIR model, which is very similar to the baseline model actually we are using, and the results are quite independent from the exact compartmental structure. Here, for the mobility, I am using an example which is mimicking the dynamics for commuting patterns, where each subpopulation is populated by a certain number of individuals, and each individual moves one of the neighboring subpopulations at a certain rate and goes back home after a certain average duration. In this case, you can group the subpopulations, assuming that all the subpopulations with a given degree are going to be equivalent. So this is a mean field approximation. And write down the recursive relations between the number of subpopulations who are infected during generation n-1, relating that to the number of subpopulations which would be generated at generation n of degree k. After a certain set of assumptions and some algebra, you can obtain a closed form for this set of dynamical equations. And the eigenvalue of the dynamical equations will determine whether the epidemic would grow or not, and which is characterized by R star. That is very similar to the concept of basic reproductive number, but at subpopulation level. It will tell us how many subpopulations would be infected by a typical infectious subpopulation. And if this is larger than 1, then you have spreading. If it is smaller than 1, then the infection dies out in a very short time scale without being able to invade the system globally. So there is a typical phase transition between extinction and invasion of subpopulations. Here in the figure I am showing the impact of diffusion rate. So this is the rate at which an individual commutes to one of the neighboring subpopulations, and in the y-axis we have the average duration an individual spans in the destination. You see the solid line gives the result obtained by analytical calculations, and the color-coded figures gives the result for the simulation, from the simulations. If you are above this line, let's say if it is not black, then you have a certain a certain fraction of subpopulations are infected, and from the actually analytical expression, you can see that the basic reproductive number at subpopulation level is determined by the higher moments of the degree distribution, which is not only the second moment actually in this case. It depends on the third and fourth moments. So it means that as your connectivity as heterogeneous it is, the reproductive number will tend to infinity in the limit of an infinite system. This tells you already that it is in the infinite system size limit, it is impossible to stop the spreading of epidemics, even though unless your diffusion rate is 0, so you do not move anywhere in the system. And I am going to show you an example which was run on a real data set, county commuting network in the United States, where we have used the census data for the populations and also the commuting fluxes reported by census, reported in the census. You see that here I am reducing the diffusion rate on each connection by a certain fraction. If you have, for instance, 50% reduction, you have almost 90% of the subpopulation still, count is still getting infected. In order to be able to get a real impact and stop it, you had to reduce all over, for sure, 95%. Even 99% would not lead to a zero fraction of the subpopulations. The simulations were started in Los Angeles County, and if you are at that 99% reduction, you have almost the West Coast actually, but when you look at the fractions, it is very close to zero. Some people could argue that actually this is not enough, so you get the whole West Coast even. So this was a way of understanding and re-understanding, let's say, that travel restrictions would not have any impact, so we should look for something else. For the GLIM, we do not integrate any type of behavioral changes at individual levels during the unfolding of the pandemic or epidemic events. However, we know that that is not true. For diseases, for mild diseases like influenza, yeah, people do not change their behavior significantly, but for some other diseases, they could do, and in this case, we would like to take into account and incorporate some social aspects of the system, so the feedback loops. Another thing we would like to do is devise similar models or structure platforms in order to make an understanding and predictions in social systems like contagion of social contagion phenomena like rumor spreading or information diffusion. And then I would like to, of course, thank many people. GLIM was done with the efforts of many researchers, and thanks to you.